we have one more speaker, and actually, after our next speaker, we're going to take a 10-minute break and then set up for the panel. And again, I encourage everybody to come up with questions for the panel, and I'm going to open that up to any questions at all pertaining to cardiology. So even if it doesn't have to do with their talks, just go ahead and fire away. All right. Our next speaker is Dr. Maite Huis, who is visiting us from the Netherlands. Maite graduated from our residency in 2016, and then the following year did the Emergency Cardiology Fellowship. She finished the fellowship in 2017, then several years later, after working on our faculty, returned home to the Netherlands, where she's really done some amazing things. She has been helping to develop the specialty of emergency medicine in her home country. She currently serves as Senior Policy Advisor on acute care at the Dutch Health Institute and also board member of the Dutch Emergency Physician Organization. And she's been lecturing nationally and also internationally. And we're lucky to have her returning almost every year now to the AAEM conference as well. Yes. So she keeps her hand in the US conferences as well. So Maite, welcome home. Thank you. Welcome home.
Thank you.
To your other home.
Yes.
And she's going to be spending some time talking about something that we're going to be starting soon, maybe a little behind the times, and that has to do with highly sensitive troponins and perhaps even the one troponin rule out, which is something that they've been doing in many other places long before we did. So take it away. Thanks.
Thank you so much, Amal, and it's so great to be back here. And I have the wonderful opportunity to stand in between you guys and lunch. So and then I got the opportunity to talk about, everybody's talking about people dying and refractory shock, and I'm just going to be talking about sending people home. So I hope I can keep you guys entertained. And when I first started residency here in Baltimore, I was super excited to take advantage of this opportunity. So many sick people, so many really, really ill people to see, so many plastic tubes to stick in bodily holes. If the bodily holes weren't there, I'd make them. But then, at the end of the day, really, there's nothing more glorious than sending a patient home to their loved ones safely. So that's what I'm going to be talking about today. Now, I do not have any disclosures, but I did point out, and I know maybe it doesn't sound so interesting or exciting to you. So lucky to be practicing in emergency medicine, a well-formed specialty that's been recognized for many, many years. I know some people in the back of the room do understand how hard it is when you have to fight for your specialty. And we've been fighting very hard for our specialty in the last few years. And finally, as of January 1st, we're recognized as a full medical specialty in the Netherlands. So that is something that is very special to me and very exciting. So I wanted to sort of give that perspective to you. Thank you so much. It's not without your help. We've received many, many letters from faculty here and all across the country to really convince the medical board in the Netherlands that we're really behind the times. So, we're kind of, you can shake hands here. You guys are specialty, high sensitivity troponins. Yeah. Anyways, we're going to be talking about this patient here because in the end of the day, that's what it's all about, right? Specialty or not, it's about our patients that we see. And this 44-year-old female shows up to your emergency department presenting with chest pain. There's some things that are a little bit concerning about her story. She says it's pressure-like, there's no radiation, no vomiting, no diaphoresis. She looks pretty good to you. But then she does tell you that her mom had a big MI at 62. So that's a little concerning. Do a physical, really nothing there. She's just sitting there. She doesn't look to be in distress. She kind of, you're not concerned about her that much. But there's some things about her story that make you want to say, well, maybe I should think about ACS, right? But not your sweaty guy sitting there. It's clearly having a STEMI. And then you think about your waiting room, right? It's completely filled up. So you're really looking to see, do you have an opportunity to get this lady out of your department as quickly as possible? Just a quick raise of hands. Who has ever, and there's no shame here, right? We're all friends. Who has ever discharged the patient with a single troponin? Yeah. Well, that's about right, because when they did a study with Kaiser Kaiser data, about 50% of the patients that were seen in an emergency department only had a single troponin done. And I'm not putting this out there to say, that's data for you to go out there and do it. I'm just saying that it's normal. There's a desire for us to do this, right? To get people home as quickly as possible. And it's also important to think about cost. I know here it's a little different. We have some sort of socialized medicine, but with 7.6 million chest pain-related emergency department visit in the US on an annual basis, getting these people out, reducing their length of stay, and reducing invasive testing leads to a 20% reduction in cost. So that is important, right? Because the patient's also going to have to pay for it as well. But is it safe, right? We want to make sure that when we do this, we get the people back to their loved ones and for them to not die at home, right? That's what we're all worried about. So very important considerations, just to sort of set a frame of reference for this talk. We're talking about low-risk patients. We're not talking about that 65-year-old smoker who's obese, who's got diabetes and hypertension, hyperlipidemia, who's sweating, sort of slithering off your gurney, clutching onto his chest. That guy, I'm not sending him home. We're talking about those people like the patient we saw earlier, where you're sort of on the fence, probably think she's fine, but need to do a little bit more than just say, you're fine, you can go home now. And then secondly, we have to talk about what kind of troponin assay are you using at your local shop. Now, I heard some great news. You guys are finally catching up to the 21st century. But, it's really important. There's a difference between the conventional troponin assay and the high-sensitivity troponin assay. Firstly, we're going to talk a little bit about accelerated diagnostic pathways. What are accelerated diagnostic pathways? They're really an opportunity for us to identify those patients safe for discharge, incorporating history, EKG, and troponin. And there's been many different ones out there. I think a big one is the HART pathway, which is the HART score, adding a repeat troponin, but there's also the EDAX ADP, ADAPT, many different ones that have been developed over time. Again, really emphasizing the desire to identify those people that are good to go home. But it can be tricky. Which one is the best one to use? Should we pick one over the other? Well, I've got great news. It doesn't matter. They're all good. They're all great to use. They have a 99 to 100% sensitivity with a less than 2% risk of 30-day MACE. And it sort of sounds random, like what is 2%? But we sort of come to agree in cardiology literature that 2% or less is the accepted risk rate for most people. Now, this could be different to you, but that's kind of what we've all agreed upon. So that's a big outcome we're often looking for. So you can pick whichever one you like. This is me on any regular shift calculating any of you guys' hardcore scores. So to me, that's an easy one to do. But if you really like any of the other ones, you're justified to do so. Then moving on to troponins, already briefly mentioned that it's very important to know what kind of troponin your hospital is using. I'm not saying you need to know all the cutoff numbers because it will often give you a frame of reference of what is normal and what is not, because they have different numbers, especially the high sensitivity troponin ones. But it is important for you to know the ones that you're using, because the conventional troponins are not so sensitive that they can pick up the raise in troponin in your bloodstream as fast as the high sensitivity ones can. So what is a high sensitivity troponin? It is detectable in 50% of the healthy population. So I could divide this room and say 50% of you guys are going to have some troponin that's going to be picked up in the blood. Mine is probably going to be a little bit higher than you guys since I'm up here, but it's normal. It's okay. I'm not having an MI. This part of the room isn't having an MI, though they aren't either. But that's part of how the test has been designed. You should have a little bit of high sensitivity troponin in your bloodstream. At least that's normal. And then there's also a high analytic precision with a coefficient of variation less than 10%. And those are all a bunch of fancy words to say, if I draw your troponin 10 times at the same time, and you run the test 10 times, the results should be within 10% of each other. So they can be 2.0, 2.2, but not 3, right? So that is kind of how they use, or how they determine that this is a high sensitivity troponin assay. Now this helps with being more quickly able to recognize those people that don't have a STEMI, but do have a rise in their troponin earlier on than those with a conventional troponin assay. but it also gives us the opportunity to more quickly rule out people who are not having a true ACS. Now, I wanted to take a moment to kind of compare the American and European guidelines, because I thought that would be fun to do. So we'll do that. So the Americans say high sensitivity troponin is best. Do it. So I'm super glad you guys are doing that as well. And the Americans you guys do make a distinction between the hours the patient has had symptoms for. So if your patient has had more than 3 hours of symptoms, and you do a high sensitivity troponin and it's negative, you can send the patient home. If the patient has had less than 3 hours of symptoms, if you have your high sensitivity troponin, you get a delta. Delta means you repeat, right? You look to see if there's any differences between 1 to 3 hours. Most people, I think, are using the shorter range of time, but you can choose 2 or 3 if you want to. And the conventional troponins, we're looking at 3 to 6 hours, so a much longer time. Then what we're saying in Europe is high sensitivity troponin is best, so I'm glad we're agreeing upon that. And then we do the 0 to 1 or 0 to 2 hour protocol, irrespective of duration of patient symptoms. And I'll get back to that a little bit. So kind of similar. And I like to refer to some studies just for you to better understand how we sort of came to these decisions. And there's many, many studies out there, but this is a big one that I wanted to point out to you. This is a study in 3,300 patients, a multi-center international trial where they did a non-inferiority study. So they just wanted to see if 0 to 1 was not worse than 0 to 3, right? They weren't looking for something better. And what they did, they looked at 30-day MACE or death, and they found that in a 0 to 1 hour protocol, they found 1.1% of 30-day risk of MACE or death. And at 0 to 3, 1.0, and that was statistically significant. So it was determined that the 0 to 1 hour protocol was not inferior to traditional care. So, I mean, that's great, but it's not better. But what was better, what they found, was that the ED length of stay was reduced by an hour, from 4.6 to 5.6 hours, which is a little puzzling to me, because something that's 2 hours less is to 1. So I don't know. So maybe this may hint at the fact that there's other factors, that make that these patients sit for a little while longer than the 2 hours you would expect. But at least an hour reduction, that's pretty good. Also, they saw that the patients who were enrolled into the 0 to 1 hour protocol, the 45.1% of them were discharged home versus only 32.3% of those in the 0 to 3 hour protocol. Now, they don't specifically mention this, but I do think that has to do with placing people in observation. I think a lot of people were thinking, well, they only have the single troponin done, and then we'll place them in observation, and then, we're not going to immediately discharge them home. Now, you could think, is that a big deal? Well, I like to think so, because first of all, you want to get people out when they're not supposed to be in the hospital, but they also saw that the rate of invasive testing was higher in those who were actually in the 0 to 3 hour protocol. And again, this is an assumption, but I think it's because, maybe while they're there, we're going to do another little bit of extra testing since you're keeping them. Whereas if you send them out, they're gone. So my take on this is that I really like the 0 to 1 hour thing. I'm doing it all the time. And I think, the guidelines support this as well. Now, I wanted to talk about single troponins, right? Because that was sort of, the holy grail of seeing patients with chest pain. Get a single test. I'm going into the Beyonce a little bit because, I don't know, recently dropped an album. Single troponin, there's been many studies done, but I wanted to look at this particular study, which was about 1,200 patients, and they had a prospective trial where they went to see if the first troponin that they did in this cohort of patients was negative, but the patients ended up with, after looking back after 30 days, with a MACE or death. And they found in a 0.7% of the people that had an initial negative high sensitivity troponin that they ended up having with some sort of AMI. Well, it's still below the 2%, and I think we're never going to be perfect here. they gave the high sensitivity single troponin a sensitivity of 99.1% based off of their data with a negative predictive value of 99.6%. So that all looks pretty good. Remember that you guidelines are saying if you've had 3 hours of symptoms, this is safe to do, right, with a high sensitivity troponin. Now, in this particular study, they didn't specify how long the symptoms have been going on for, so that was sort of interesting. But, you know, when the patients had that in the US guidelines, it's fine to send someone home. We say that it's better to do the repeat troponin after an hour. And the reason ESC, the European Society of Cardiology, has chosen to make that statement is because they say for practical purposes and kind of a protocolized care for these people, it's better to just repeat it. Patients are also a little bit bad about, you know, knowing how long they've had symptoms for every now and then. And we have specialized cardiac emergency departments where the nurses do, you know, the majority of what they do is see chest pain patients. So for them, it's very easy to just automatically repeat that troponin and you're done within that extra hour. So I really like doing that. So that's sort of my practice. Some people say, well, you're done within an hour and, you know, it's easy to do. But I think if you're really not that concerned about chest pain, then don't get the first one to begin, with chest pain patients, you're not concerned about a cardiac origin of the pain, then don't get the troponin at all. But if I do, then I repeat it in an hour. Then I also wanted to touch briefly on the Dutch EMS system wanting to pick up pre-hospital point-of-care troponins. There's been a couple of studies done, and currently they're still doing a study on pre-hospital troponins. And one of the studies they did was the Artica trial. And what they did is they went to people who called EMS for chest pain, and they randomized them to either doing the intervention or not. And the intervention people, what they got was a point-of-care troponin done in the ambulance. Now, mind you, the point-of-care test is a conventional troponin, not a high sensitivity. And if it was negative, they did not bring the patient to the hospital, but handed them over to the primary care physician's care. And it was up to them to determine what to do with these patients. And then for the control group, they just did the regular stuff. So they just brought the patient to the emergency department. And really, this was a cost reduction trial. I don't know why they started with that, but that's what they were looking for. They did also look at risk of MACE, but the study was not powered to do that. Now, when they looked at risk of MACE, for the intervention group, for those people that, you know, got the point-of-care troponin in the ambulance and were sent home, the risk of MACE was 0.5% compared to 1% in the control group. And we saved 600 euros. So I think, you know, it's a little tricky to really, and this is interesting data, right? Because it's promising. But to me, this is not a game changer as of yet. I have some concerns about it being the conventional troponin assay. The point of care is probably not as good as the regular lab test. But this sort of shows that the majority of the people that are included in these trials who have a HAR, so not the T, the heart score, you know, but without the T, of 0 to 3, they're so low risk of having true ACS. And I think that really proves that we've gotten really, really good at picking out those people that actually do have ACS. Now, the famous trial, what they did, it was a little different. So they saw people with low risk ACS. So they had a heart score of 0 to 3 in the ambulance, or HAR score of 0 to 3 in the ambulance. And at the time they saw the patient, they drew a lab test. So they drew a little vial, transported the patient to the emergency department, had the results of the high sensitivity troponin they did in the ambulance blinded to the study team, and they went to look back to see if there were any elevations in the high sensitivity troponin, and looked to see if those that had a negative result ended up with MACE. It's a lot of, but you know, those who had low risk chest pain, had a high sensitivity troponin done in the ambulance, if their result had been negative, would it have been safe to send them home? And they found that the risk of MACE in the cohort study was 0%. And this was 1,200 people. So this is interesting data. To me, we're not quite there yet because this is a high sensitivity troponin test done in the hospital, not a point-of-care conventional one. So it's hard to say what this really proves for that point-of-care one. So I'm a little bit nervous about this still, but the Artica people are doing a bigger trial. I do also have to add the frame of reference that we have an excellent primary care system. You know, my daughter had a rash that started getting infected. I called the clinic at 8. I was at the clinic at 8:10. I was out of the clinic at 8:15 with a prescription. My daughter was in school at 8:30. And I mean, she had a little rash. So our primary care system can see people same day. They can follow up on people. They know the patients. So that is sort of, you know, tricky about translating all this data to the American system where that is unfortunately lacking. But promising data to follow. So going back to our patient that we saw, she had a delta troponin of negative and negative, and she was discharged home, and she had no any-day MACE. And she was very happy because she just, you know, was able to go about her day. To summarize what we've discussed here today, accelerated diagnostic pathways are safe to use. You can pick whichever one you like. High sensitivity troponin protocols with 0 to 1 are safe to use. And single troponins may be safe, but we need a little bit more data, in my personal opinion. I want to thank you so much for your attention and for this opportunity to come out here, and I will gladly take any questions.
All right, great. Since we're going to take a break right before the panel, why don't we just do that right now, and then we'll hit you with some questions after that. So.